All right, let's jump right into a clinical case you are absolutely guaranteed to see both on your board exams and out on the wards. We're talking about high calcium. We're going to crack this case step by step and get to the bottom of its most common cause, primary hyperparathyroidism. Okay, so put yourself in this situation. You're clicking through your patient's labs, just a routine check, and then bam, you see it. Serum calcium 11.2. Now that's not panic level high, but it's for sure elevated. And the crazy part? The patient feels totally fine. They're completely asymptomatic, which you'll find is actually how this usually presents.
So, of course, your attending turns to you and says, "All right, what's our next move?" This one little lab value, it's the start of a really important diagnostic journey. So, what do? What is the single most important thing to do next?
Okay, so that brings us to our crucial first test. This is all about pinpointing the problem. Before you start ordering a million different things, you got to know that there's one test that's going to unlock this whole case for you.
So here it is, the initial workup. It's a simple two-step process, but it's absolutely critical. First things first, always repeat the lab. You have to make sure it's a real finding and not just some fluke. Once you've confirmed it's real, then comes the game changer. Step 2, you order a serum calcium and a parathyroid hormone or PTH level. And here's the key, they have to be drawn at the exact same time. That part is totally non-negotiable.
And this is why that one test is so powerful. It basically splits your entire differential diagnosis right down the middle into two big buckets. Look, think about it logically, right? If your calcium is high, your parathyroid glands are supposed to get the message and just chill out. They should stop making PTH. So PTH should be low. But if your PTH is high or even just normal when the calcium is high, which is completely inappropriate by the way, then you know the problem is the parathyroid glands themselves. They've gone rogue, and that right there is your PTH-mediated hypercalcemia.
So for our patient, the PTH comes back inappropriately normal. And that points us straight toward the number one cause of this whole situation. It's time to unmask the culprit, primary hyperparathyroidism.
So, what is primary hyperparathyroidism? Well, most of the time, we're talking about a single, benign tumor, an adenoma on one of your 4 tiny parathyroid glands. Think of it like a rogue factory that's just pumping out PTH 24/7, completely ignoring the body's, "Hey, we have enough calcium" signals. And a key thing to remember for your exams is the classic demographic. You'll see this most often in women, usually around their 60s.
Okay, every med student has to learn this classic mnemonic, right? Bones, stones, abdominal groans, and psychic moans. It's a great way to remember the potential symptoms: osteoporosis, kidney stones, GI upset, and even things like fatigue or confusion. But here is the massive clinical pearl you need to take away. Most patients you see today will be just like ours. They'll have 0 symptoms. It's almost always found by accident on routine labs.
And this image, wow, it really drives home the bones part of that saying. All that extra PTH is literally pulling calcium right out of the skeleton, making the bones weak. What you're looking at here are severe vertebral compression fractures. This is exactly the kind of damage we're trying to prevent. It's why we don't just ignore this, even when the patient feels fine.
All right, so you're probably thinking, got it, primary hyperparathyroidism, case closed. But hold on, not so fast. Before you even think about calling a surgeon, you have to consider the mimics. And one of these is a total classic board exam trap that you do not want to fall for.
Okay, let's talk about the key mimic, FHH, or familial hypocalciuric hypercalcemia. It's a mouthful, I know. Basically, it's a genetic condition where the body's calcium sensor is broken, so it always thinks calcium is low even when it's high. The result? High calcium and high PTH, just like in our patient. So how do you tell them apart? It all comes down to the urine. In FHH, the kidneys are desperately trying to save calcium, so they don't pee any out. The urine calcium is super low. And the definitive test you have to order is the calcium to creatinine clearance ratio. If that ratio is less than 0.01, it's FHH. And this is a huge deal because FHH is benign and needs 0 treatment.
And this is so important, we're highlighting it with a direct quote. Just think about what this says. A simple 24-hour urine collection is the one thing that separates someone who might need surgery from someone who needs absolutely nothing. You have to do this test. It is a critical step in the workup.
Okay, let's just quickly rewind for a second. Remember that first fork in the road. What if the PTH had come back low?
Well, if you've got high calcium and a suppressed PTH, your alarm bells should be ringing for one thing: malignancy. That's a totally different ballgame and a much more urgent workup. But let's get back to our patient. The urine tests came back, FHH is ruled out, so we have our diagnosis: asymptomatic primary hyperparathyroidism. Now we get to the really big question, the management decision. Do we operate or do we just watch and wait? And this really is the core dilemma, isn't it? Your patient feels perfectly fine. How can you recommend they get surgery? Well, the good news is you don't have to guess. There are very clear evidence-based guidelines that tell us exactly when surgery is the right call. Here they are. This is your checklist for when to operate. The basic idea is simple. You pull the trigger on surgery if there's already evidence of end organ damage or if the patient is at high risk for it. So we're talking about a calcium level more than 1 point above normal, any sign of kidney problems, or a T-score that shows osteoporosis. Another big one is age. If your patient is younger than 50, you lean towards surgery. And of course, if you find kidney stones or a fracture on imaging, that's a definite green light for the OR.
So what about everyone else, the people who don't meet these criteria? We just watch them, right? Well, that leads us to a really striking statistic.
It turns out that about 1 in 3 of those patients we decide to just watch will actually develop a reason for surgery within about 10 to 15 years. And that's a huge point. Watchful waiting doesn't mean do nothing. It means you're signing up for a commitment to long-term follow-up. We're talking yearly labs and regular bone density scans.
And that really leaves us with the big lingering question, doesn't it? If so many of these patients are eventually going to need an operation anyway, is watchful waiting just delaying the inevitable? There's no easy answer. It's one of the central debates in managing this condition, and it's a question you're going to face again and again in your career. Thanks so much for cracking this case with me today.